our next speaker is Janine Brandt, who is a. So Janine, you're an advanced practice nurse, clinical nurse specialist. Okay, like Deanna, like my friend Deanna, who is a pain consultant at Billings Clinic and actually has been working on pain for at least as long as I have, and probably longer. She's also been really key in helping develop the syllabus around something called the PRN training, which stands for Pain Resource Nurse, which is a fabulous syllabus for you to get to use in your facilities. We're at Bozeman Deaconess, we're going to be doing a training starting on Monday, which is a day and a half training for nurses who are involved both in the hospital and in outpatient settings to train them around nursing. So, Janine?
Thanks, Catherine. I'm delighted to be here today. And my husband so kindly reminded me on the way over that the last time we stayed here was for our honeymoon. And I thought, oh my gosh, I forgot all about that. So I shouldn't have said that. The honeymoon suite actually used to have a full-size swimming pool in the room. I don't know if it still does or not, but it was kind of fun. So he also reminded me he's a little grayer than he was the last time, but okay, I'm going to get down to the nuts and bolts of pain management and talk about Pain Pharmacology 101. So a little bit about what I'll talk about in a second, but I'll start with this this quote by Plato. It says, "Be kind, for everyone is having a hard battle." And I think in the day of addiction and the problems that we have, we can't replace the fact that we have to listen to our patients. We have to believe their reports of pain until proven otherwise. Okay, so the medication options I'll be talking about include the non-opioids, the opioids, and the co-analgesics. So I've got a lot of content for you. Everything else prior to this has been kind of foundational. June's talk will also be very instrumental when I talk about some of these modalities, because some of them start at the periphery, some of them are centrally mediated, and follow the different pathways of pain, transduction, transmission, and modulation. Okay, let's talk about the non-opioid analgesics. These are the agents that probably most of you are very familiar with. A lot of them are over the counter. They're effective in mild to moderate pain. In fact, let me ask you, how many of you have taken, if you're willing to say, one of these non-opioids today? Has anyone taken one? Quite a few, exactly. These are the drugs we use all the time. Again, usually effective for mild to moderate nociceptive pain. None are really effective in neuropathic pain, and all have an analgesic ceiling dose. Starting with acetaminophen, and June talked about some of the concerns with this and the FDA regulations, but acetaminophen really does have some significant side effects that we have to look at. It has analgesic and antipyretic activity, but it's not an anti-inflammatory. So it doesn't have the other side effects of some of the non-steroidal agents as well. It is synergistic, and it's contained in a lot of multiple opioid products. So, for example, the oxycodone acetaminophen products, the hydrocodone acetaminophen products. What's the major concern? Of course, hepatotoxicity. Greater than 4 grams is definitely considered hepatotoxic. And patients with liver compromise can have an increased problem when you exceed 2 grams a day. Then we go into 3 classes of non-steroidal anti-inflammatory drugs: the non-acetylated salicylates, the non-selective non-steroidals, and then also the COX-2, which we only have 1 left at right now. Okay, as far as the non-acetylated salicylates, what are some of the advantages here? Well, these are the first that were approved after aspirin. So aspirin's kind of the olden days. Speak up, okay. Can you guys hear me now? Is that better? Okay. Decreased GI complications for sure, and no antiplatelet effect. Also, a lower cardiovascular risk than some of the other NSAIDs, and I'm going to talk about that cardiovascular risk in a minute. Some of these agents you may not be familiar with because they're not used as often anymore, but keep them in mind as potential options for patients who have a high risk for GI toxicity. As far as the non-selective agents, they're on the board here. The couple I'll point out, ketorolac, of course, or Toradol is the one injectable nonsteroidal we have. Very helpful for postoperative pain. There's some controversy about it inhibiting bone healing. However, those studies have been very controversial. So it's still a very helpful modality for the anti-inflammatory aspect of postoperative pain. Also, naproxen, I'll point out, is one agent that has less cardiovascular toxicity than some of the other nonsteroidal agents. And then there are the cyclooxygenase 2 selective nonsteroidal anti-inflammatory drugs. When these were first approved by the FDA, one had hoped that they would have less GI and renal toxicity than the other nonsteroidals, because there's a two-part pathway where there's an inhibition of cyclooxygenase 1 that leads to vasodilation of the renal area, prostaglandins which coat the GI tract, and what happens is when you inhibit that pathway, you cause GI toxicity or potential bleeding, especially with the inhibition of platelet aggregation. You also cause renal vasoconstriction, so you have the renal toxicity. What they found, though, was that these are really no safer than some of the other NSAIDs that are currently out on the market. There is a decrease in GI complications, so it doesn't appear to inhibit that prostaglandin quite as much. But however, if given long term, there are some potential long-term side effects. The problem was the increase in the cardiovascular risk and the increase in the thrombotic events that occurred with these. We know that there were 3 on the market, and now only 1 exists, and that is the celecoxib that can be taken once or twice daily. So what are the advantages of the nonsteroidal agents? Well, they definitely have analgesic properties. They're very helpful as an anti-inflammatory agent. In fact, many patients with arthritis and bone problems, because they work on the periphery, and when June talked about transduction and the signal starts in the periphery, you actually have some neurochemicals that come together in the periphery. Prostaglandin is one of them. There's some others as well, but that's where the signal starts, and that's where the inhibition takes place, is right there at that area. So they're very helpful agents. They're also antipyretic, and they're synergistic with opioids. They're not controlled, so they're easily prescribed. They're effective for primarily nociceptive pain, somatic pain, which is bone pain, sometimes visceral pain, which is organ pain. However, they're not effective in neuropathic pain, as I said before. The other thing is after a patient has responded to one, they might respond to another one. Again, available over the counter. There are topical preparations available. And I think when we talk to older patients and they have so many pills out, I have aging parents, and so we're always going over their medication, so if they don't have to take another pill, that's very helpful. So there are a couple of topical preparations available. For example, the diclofenac gel, you can apply that systemic or topically. About 6% of that goes to a systemic absorption, so it's pretty low, but you also want to watch it with combination nonsteroidals because there can be additional side effects. You can get the combined side effects with those. Okay, what are some of the disadvantages? Not really effective for neuropathic pain. They have a ceiling effect, so you can keep going up with the dose and you're going to get more toxicity, but not necessarily better pain relief. And then we can't underestimate the GI toxicity problem that we have of 16,000 deaths per year and 200,000 hospitalizations per year due to GI bleed. So as far as the safety profile goes, these are by far less safe than the opioids that we'll talk about in a minute. One thing, of course, that we need to do in these patients, especially those high-risk patients, is to prophylax them with a proton pump inhibitor, and this can really decrease that incidence of GI toxicity. What's the other problem? As I mentioned before, There is an inhibition of prostaglandin I2, which promotes normally renal vasodilation. So when you get that constriction, you have the potential for renal toxicity. And part of the problem is when patients are inadequately managed for pain in the community, they will take a lot of nonsteroidals, which will actually throw them into renal failure. Even if you have an older patient who is dehydrated and takes a lot of a nonsteroidal, it could actually throw them into renal failure quite quickly. Platelet inhibition, of course, is the other disadvantage, causing bleeding. And then what about the cardiovascular toxicity? There's really more going on in this area. The American Heart Association is looking at this. Data are sparse. We know there's a higher risk in patients with a prior history of cardiovascular disease. There is that lower risk with naproxen, like I mentioned, but there is an increase in the thromboembolic events in myocardial infarction. And also some possible CNS toxicity with NSAIDs, confusion, and sedation. I just wanted to point out, though, that the American Heart Association recommends that short-acting opioids are preferred for the short term before non-steroidal anti-inflammatory drugs. So again, we're really on the bandwagon to use non-steroidals because they're non-opioids and all of the fears that are out there. But if you really look at the toxicity profile, you will see that these are more dangerous drugs to give than opioids. As far as the MI rate, for patients taking long-term non-steroidals, a systematic review of over 130 studies showed that there was an increase of about 1 in 300 patients had a myocardial infarction on a on long-term non-steroidal use. Okay, let's talk about a case study, and I'm going to kind of weave her in and out of the talk this morning. We'll talk about Dorothy. She's a 75-year-old female with osteoarthritis in her knees. She has type 2 diabetes, New York stage 1 congestive heart failure, so pretty mild. She states she can no longer walk her dog and finds it almost impossible to go grocery shopping. She finds she's becoming housebound due to the pain in her knees. Typical situation. She started on acetaminophen, 650 milligrams 4 times a day. She does get some relief primarily at night when she's not very active. She does not wake up in quite as much pain, but it doesn't take much activity before the pain returns. So she did receive weekly Synvisc injections times 3, but doesn't really think that they were helpful. She can only walk a half a block with the dog. She does not want to grocery shop. The pain still interferes with most daily activities, so what now? Okay. Here's a couple possibilities. How many of you would give her a steroid injection at this point? Couple. And actually, that probably should have been tried even before the Synvisc. Okay? What about a knee replacement? Possibly, depending on what the x-ray showed. What about opioid therapy? A few. Okay? What about co-analgesic therapy? Some others that we'll talk about. Okay? And sometimes there's no right answer, so we're going to go on and we'll see what happens. That's the difficulty with pain management too, is that it's so individualized per patient, and sometimes there aren't right answers. And I think Catherine pointed out, we have some evidence, but we don't have really good evidence for a lot of things. Okay, let's talk about the opioid analgesics. We have 2 different categories, and June talked about the transduction of pain and then the transmission of pain to that dorsal root ganglion and then to the dorsal horn of the spinal cord. This is where these agents work. What we have is different receptor sites at the dorsal horn of that spinal cord. We have mu receptors, we have kappa, and we have delta receptors. Pure mu agonists bind to that mu receptor and prevent the transmission of pain from going up that pathway. So they block that receptor site area. The agonist-antagonists, on the other hand, they bind to kappa and delta, a different subset of opioid receptors, and they antagonize the mu receptor. So this has implications. If you have a patient on an opioid agonist and you actually give them a mixed agonist-antagonist, it can actually precipitate withdrawal. These different receptors also mediate different processes that we see in pain. For example, you actually have more respiratory depression with a mu agonist, potentially more euphoria. The mixed agonist-antagonists are really responsible for mediating a lot of the spinal analgesia. And as you see, in a minute, one of the few things that we use those for is with intraspinal analgesia, you can actually give one of the mixed agonist-antagonists to reverse some of those receptors and prevent itching in those patients. But otherwise, their use is minimal. Okay, so now I'm going to go through the primary opioids that we use to manage pain, and I'll start off with morphine because morphine is pretty much the gold standard. Morphine is a variable drug. It's available orally, IV. You can give it subcutaneously. You can even give some of these oral preparations into the rectum, and sometimes we do that in the palliative care situation. Most people tolerate morphine quite well, although some do have some nausea with it. Some people get itching with it. The important thing, of course, is to start low, go slow in most patients when you're starting therapy. But what we do need to be aware of are the two metabolites with morphine. One is M3G, or morphine 3-glucuronide, and the other one is morphine 6-glucuronide. M3-glucuronide is a neurotoxic metabolite, and so the more it accumulates, the more it can cause side effects, potentially myoclonus, and possibly hyperalgesia. So it actually antagonizes the analgesic effect, and causes some side effects. On the other hand, M6, or morphine 6-glucuronide, is actually more potent than the parent compound itself, which means that the longer you dose morphine, the more efficacious it becomes. And for those of you pharmacists who have seen an equianalgesic table, we used to have this in the table. It used to be a 1 to 6, like 10 of IV equals 60 of oral morphine. And then with chronic dosing, it said 10 of IV equals 30 of morphine. Do you remember those old tables? And that's because of some of these metabolites. And now we kind of say it's a 1 to 3. The important thing is that these can accumulate with renal insufficiency. So patients can build up these metabolites. They can become more sedated, have more side effects, and there is a higher metabolite accumulation with the oral route because you have the first pass effect through the liver and more metabolite accumulation. The next opioid I'll talk about is fentanyl. Fentanyl is a drug that I think we're starting to use more in clinical practice. It's a very different drug because it's lipophilic. And by lipophilic, it means it loves fat, so there's a very nice distribution. However, pharmacologically, it's a very different drug depending on how you give it. For example, if you give it IV or subcutaneously, it has a fast onset, but it also dissipates very rapidly. I can tell you that I had a patient a while back, cancer pain. We had her on about 1,000 micrograms of fentanyl an hour. We took her to the OR to have a spinal placed, and they removed the fentanyl, and they removed it too soon because they lost the route of administration. She actually went through some withdrawal within an hour because it leaves the system very quickly. So that's one caution with that. If you use a continuous infusion, a lot of times it's combined with, or a bolus dose, it's a lot of times combined with a continuous infusion. What about transderm fentanyl? Very different. Duragesic is the trade name. There's others out now as well. But it has an onset of 12 hours. So until it starts working, we have to put other pain medications in place to keep the patient comfortable. Then it has a peak of 24 to 48 hours. You have to make sure not to heat it. It can release more quickly. If there's an adhesive reaction, there are a couple of things on the screen that you can use to do to prevent that. The other thing is be careful with this agent. I think providers underestimate the potency of this. The patient has to be able to tolerate about 60 to 75 milligrams of oral morphine in order to tolerate a 25 microgram patch. So these should not be used in opioid naive patients. Now that there is a patch available, 12.5 micrograms, we're seeing that used a little bit more, but you have to still be very careful with this. The two others are the transmucosal. We have Ventora and Actique. Ventora is like a pastille, and Actique is a lollipop. Very fast onset. Really, I like to use these for procedural pain or also for patients who have a lot of incident pain. For example, every time they sit up, they have excruciating pain. So if they take one of these medications before they sit up, again, a lot of times in cancer care, then they will be comfortable when they go about moving. Hydromorphone or Dilaudid, hydrophilic drug, has a lot of different routes available. One of the things we're lacking is a controlled release medication with hydromorphone. There was one on the market a few years ago and it got pulled because of its effects with alcohol. The other thing with hydromorphone, though, is it's very potent, and I think that providers sometimes underestimate the potency of this agent. For example, 1.5 of IV hydromorphone equals 7.5 of oral. Or when you compare that to morphine, 7.5 oral equals 30 of oral morphine, or 1.5 IV equals 10 of IV morphine. So we really need to respect this agent. It does have a couple of active metabolites, but there's little data on the impact of these metabolites. I can tell you last week I managed a patient. We had her on. She's a 39-year-old gal with cervical cancer, metastatic. In fact, Roxanne's in the room. I think you worked with this patient as well. We titrated her up, and she was taking about a gram of hydromorphone a day, 1,200 milligrams, and she developed severe myoclonus. In fact, she came back into the hospital with a status epilepticus. So we started her on a midazolam drip, and were able to maintain her pain control. And the midazolam, or the Versed drip, was at 12 milligrams an hour, and she was awake, alert, oriented, and very comfortable. But likely the metabolite accumulation caused this, but again, there's lack of studies that are really showing this evidence. Oxycodone. Oxycodone is also widely used. Controlled release form, immediate release, oftentimes combined with acetaminophen. It's 1.5 times stronger than morphine, and sometimes clinicians don't recognize that. It does have a mediation by CYP450, but the implications are not clear. In fact, studies really showed that it's the active oxycodone, not the oxymorphone, that's responsible for over 90% of the analgesic response. With controlled release, I just want to remind people you do get a nice biphasal peak at 1 hour and 6 hours, so the curve actually pops in right away, and patients can get fairly good relief with oxycodone. Oxymorphone is an opioid that many of you might not be as familiar with, and like fentanyl and like methadone, it's another lipophilic opioid. So, and I'd love to see more studies on uses of these hydrophilic versus lipophilic agents, because clinically, sometimes we see, depending on the pain syndrome, a different response with these, especially if you have hard to reach pain like a brachial plexopathy. But again, we don't have the data to look at that. It is stronger than morphine, as you see. It's available in immediate release as well as controlled release. The one thing we have to watch on this agent is the area under the curve increases significantly with a high-fat diet by about 38%. Also, alcohol increases that curve, and so patients should not take this agent with alcohol. Now, one of the proposals, because some of these newer agents have different properties depending on if they're dosed on an empty stomach, one of the ideas is to dose reduce them and allow them to take it with food. So those are things that you have to work out with the patient. There are a lot of potential for hepatotoxicity, though, with an increased area under the curve. So again, to dose modify for those patients. Methadone. My colleague Leanne's going to talk more about methadone this afternoon, but methadone's an interesting agent, and we're starting to see it used more and more, probably because of cost. And we have to be careful with this agent, which she'll talk about, but it is lipophilic. It has a very long half-life, and it's not controlled released, but it's protein bound, so it works by spacing out the dosing at about every 8 hours because of its highly affinity for protein. So it binds to protein, but one of the problems is that drugs can compete for those protein binding sites, and then they get knocked off their binding site. You've got a lot of systemic drug hanging around and a lot of potential for toxicity, and then with the long half-life. So there's some precautions. The ecoanalgesic dosing is a challenge as well. There's also some cardiotoxicity potentials. Whoops, not sure what happened there. It can cause a lengthened T wave, a prolongation of the T wave. So patients that are taking over 100 milligrams a day, we should really monitor their cardiac function and look at an EKG at least annually. This is a new agent that Catherine was talking about. It's tapentadol. And originally, the company was hoping for a Schedule III drug, but in June of 2009, the DEA actually agreed to the Schedule II drug. It's a very different agent in that it's more similarly structurally close to a drug called levorphanol, which we don't see being used a lot here. But in addition to being a mu opioid, it blocks the reuptake of norepinephrine at the central nervous system. And as June talked about, we have these descending modulating mechanisms where the body's trying to put more neurotransmitters at the central nervous system to block that transmission of pain to the brain. Well, this drug and others that we'll see block the reuptake, so it keeps more of that neurotransmitter right at that dorsal horn area. It's been estimated to be a potency between tramadol and morphine, but ecoanalgesic doses have not really been looked at yet. So where it's going to be in the armamentarium for pain management, I think it's still hard to see. Because diseases like fibromyalgia and others possibly have some complications with modulation, we may see a role in that disease and in other similar diseases. Has anyone used this agent yet? A few of you, okay? Okay, buprenorphine. Buprenorphine is another one that's receiving increased attention, primarily because of the difficulty in abusing this medication. It's a partial agonist, but it's very tightly bound to the receptor. So what happens is if you take opioids while you're on buprenorphine, you won't respond to the other opioids if the receptors are saturated. So think about this. This can be problematic too. Let's say you have a patient on buprenorphine and that patient gets into a motor vehicle accident. You try to treat them on opioids and it's very hard for the pure mu opioids to saturate those receptors. So there can be some concern there. However, it can be very helpful in those high-risk patients with abuse potential. Suboxone is formulated actually with naloxone in it to discourage abuse, so such as injection and snorting. And this is one of the tools that companies are using to try to achieve good pain control, but also to try to prevent abuse and diversion. So there's this constant balance of, again, keeping patients comfortable, but using these medications and protecting the practices of pain management by preventing some of these issues. Okay, some other opioids. Hydrocodone. Interestingly, we always think of hydrocodone as kind of being one of those drugs that, is used for a lot of different things. I think clinicians feel that it has a less abuse potential. I can tell you that it is the most widely abused opioid in the United States because it is so widely prescribed. It's usually combined with hydrocodone, so that limits its dosing. It has a ceiling dose because of that, but is actually very well tolerated by a lot of patients. You do have to watch the acetaminophen content, however. Some of these agents have as much as 750 milligrams of acetaminophen per tablet. So again, we're really going over those 4 grams. Codeine. Codeine has had a role in pain management for a long time. We see it a lot in pediatrics as well. On the next slide, though, I'm going to talk about some of the problems that we see with codeine. It is available in the liquid, so sometimes that's an advantage for kids and why it's used. Tramadol. Tramadol is a codeine analog, and as I mentioned before with the new tapentadol, this also, it's not really scheduled mu agonist per se, but it does bind some to the receptors, but it also blocks the reuptake of norepinephrine at the dorsal horn of the spinal cord. There's both long-acting and short-acting available, but one of the problems we've seen is seizures with this drug, so it's being used very carefully, especially in older patients. Patient variability. This is medicine of the future, where we can look genetically at somebody's makeup of which drug are you most likely to respond to, which genetic alterations and aberrations are specific to you, and then individualize medicine as such. We do know that the P450 CYP2D6 is one mechanism to metabolize drugs. And we know that some drugs go through that pathway and that there are individual variants with that process. There are individuals who are what we call poor metabolizers. For example, codeine is a prodrug. Codeine has to be broken down to morphine before it can release its analgesic activity in the body. If the patient is unable to metabolize the codeine to the morphine, and this is true in 7 to 10 patients or Caucasians, less of African Americans, and even fewer of Asian patients, they will have no analgesic effect from that codeine. Now let me talk on the flip side of that. What about the extensive metabolizers? There are people who can individually convert this rapidly. There is a case study, and you can go to the FDA website, where a nursing mother was taking codeine for her post-C-section pain. She was an extensive metabolizer, nursing a baby, dumped the drug to the infant, and the infant died of a respiratory depression and arrest. So again, it's a drug that we need to use cautiously. What other drugs go through this process? Well, tramadol, hydrocodone, oxycodone, but again, the thought is that the parent drug is responsible for the analgesic effect, not the metabolite, so we don't think there are a lot of implications with this. Fentanyl is another one. There are drugs that inhibit this process, though, and I think when Leanne talks this afternoon about methadone, you'll see all of the drug-drug interactions with that. Okay, let's talk about the bad players. Propoxyphene. Did anyone see in the news where there was a lot of discussion even about pulling propoxyphene off the market? Did anyone see that? There's been a lot of discussion lately. And why? What's going on with propoxyphene? Well, it has a lot of cardiovascular and central nervous system toxicities. It can be a psychologically difficult drug. It causes some psychometric effects. It's very weak analgesic-wise, and there again is a lot of acetaminophen. One Darvocet N100 has 650 milligrams of acetaminophen per tablet, so a lot. Okay, what about meperidine? Hopefully by now everybody is aware of the toxic metabolite of meperidine. The metabolite is called normoperidine. It can accumulate and cause central nervous system toxicity, including grand mal seizures. You can give naloxone, try to reverse it. It doesn't reverse it. In fact, it can make it worse. The American Pain Society says that it should not be used for more than 48 hours or at doses more than 600 milligrams a day, and it's definitely not recommended orally where you see more metabolite issues. Okay, I don't know. Okay, here's some other bad players, and I'll just list them real quickly. Pentazocine, butorphanol, and nalbuphine. And like I said, once in a while you'll see a small dose being given to reverse pruritus in a patient on an intraspinal analgesia like an epidural because the agonist-antagonists mediate that activity. But otherwise, these usually are not used, especially for chronic pain management. Okay, so that's kind of a general overview of the opioids. But one of the things I believe that we all struggle with in clinical practice is how do we titrate these opioids? You start a patient out, and you might even start them with a Tylenol combination, but then how do we titrate from there if patients are having more pain? Well, we definitely want to start low and go slow in the elderly and then the opioid naive. In patients with chronic pain, patients with cancer pain, you may need to go more aggressively. The guidelines usually say to perform titration after reaching steady state. This is an average of 4 to 5 half-lives for IR agents and 2 to 3 days for sustained release. For example, for a transderm fentanyl, you don't want to titrate it any more than once every 3 days. Dosing titration is a little different depending on the source you look at. And again, these are clinical recommendations, but they really lack evidence as far as the efficacy goes. But the general rule is about by 25 to 33%. And what I see oftentimes happening is if you have a patient on 10 milligrams of oxycodone every 6 hours, and then you go up by just a couple of milligrams. So we really need to jump by a percentage. And then the breakthrough dose should be a percentage of the 24-hour dose. So I gave the example there. So for example, the patient is taking morphine sustained relief 200 milligrams per day, okay? The breakthrough dose would be 10 to 20%. 10% would be 20 milligrams. 20% would be 40. So about 30 milligrams of MSIR would be a breakthrough dose. Another way to titrate would be to add all of the IR doses the patient's taking to the sustained release dose and increase it there. But let's say we're going to increase this again. So then you say, well, let's take about 25 to 33% of the 200. It's maybe about 50, 60 milligrams. So then we would be at 260 milligrams for the next titration. So what would be the breakthrough dose? Well, 10% would be 26 milligrams, so we're still in range, or twice that, 52 milligrams for the upper range. So what you could say for the breakthrough dose now is 30 to 45 milligrams for the breakthrough dose. When do you decide to rotate an opioid? So let's say the patient's been taking morphine, and again, unfortunately, what we commonly see, instead of rotating, we add. And sometimes our order sets and our orders get so complex, the patient will be on oxycodone, then somebody will add transderm fentanyl, and then we'll add a little bit of hydromorphone, and we keep piling the opioids. So it's best to completely take them off one in most cases and rotate to another. If you've titrated, and again, aggressively titrated without analgesic improvement, and there are intolerable side effects. And again, we don't know what the genetic and the individual variability is out, but we're starting to learn that. But we do know that individuals may respond differently to different opioids and different modalities. Use an ecoanalgesic chart as a guide and consider dose reduction because of the lack of complete cross-tolerance between agents. So let's look at Dorothy. She's now taking 2 Percocet every 6 hours. Pain control's fair, but she's waking up at night with severe pain. She has a total knee replacement scheduled in 3 months. But she wants to delay because her daughter's getting married. And this is typical with joint replacement. Patients wait until the last minute. They try to put it off as long as possible. However, so she needs something long-acting. And this is another driver in our healthcare system. It'd be nice and easy to keep her on oxycodone. Her healthcare plan will only pay for morphine. So let's rotate her. So her total dose of oxycodone is 40 milligrams per 24 hours. So 20 milligrams of oxycodone is equianalgesic to about 30 of morphine, as 40 that she's taking right now is to X of morphine. You cross multiply, so 20X equals 1200 and X equals 60 milligrams in 24 hours. Now the question, do you decrease the dose for lack of cross tolerance? Sometimes it depends on how well their pain's controlled, how tolerant they are. But anyway, you can kind of see the couple of options that you would have depending on her situation. Okay, what about parenteral opioid dosing and titration? Well, this includes IV and subcutaneous routes, and now we're getting into more chronic pain management, hospice pain management when we talk about these routes, but also in the hospital post-operatively, we use IV a lot. Just a note though, when you have a patient on an hourly infusion rate, you titrate again by about the same percentage, but sometimes the rescue doses are at a higher amount. So for example, if somebody is on an IV drip of 10 of morphine an hour, the bolus dose would be 5 milligrams. And then you titrate again by about 33%, more if it's intractable, so up to 13, and then the bolus dose would be around 6 or 7. So again, what I want to show you is that logical progression up, but you always have to move the breakthrough dose along with the continuous infusion dose. So what routes can we rotate to? Well, here are all the routes that we can deliver pain medications by, and did you notice that I do not have the IM route of administration? Now, I know that there's a couple of people who work the ED here, and I know occasionally you have to give an agent if you need to IM. However, many of these can be given subcutaneously instead of intramuscularly, and you will have a more even response, because IM, it's a highly variable route of absorption, and it's very variable as to whether patients will respond. But we have a lot of ways to give pain medications. So when should we change an analgesic route? Let's say you're working with a patient, you've titrated the doses, maybe they have nausea and vomiting, maybe they're lacking that mental clarity, and oftentimes what we get into is we'll titrate the dose up and they're just not as mentally clear as they would like to be. That may prompt a decision to change routes of administration with symptoms or inadequate analgesia. In primary care, though, one of the considerations in pain now with some of our more invasive modalities would be to go to that intraspinal option, for example, in an implantable pump. One of the advantages is the closer that you get to that spinal level, the less medication that you need to use. For example, let's take 600 milligrams a day of oral morphine. That equals about 200 a day of IV or subcutaneous morphine. Then it goes about a 1 to 10 to the epidural, so it goes to 20. And then to the intrathecal level, it's another 1 to 10 ratio. So you can see the small amount of drug that you're using. However, again, these pumps, they're invasive. They're usually lifetime. You have to refill them, but they are a very nice option to chronic pain management in some patients. Okay, we've touched briefly on some side effects, and we will do so again because opioids are associated with a lot of side effects. Constipation, let me tell you. We talked about constipation. Catherine talked about constipation. It is a primary reason why patients will say, I do not want to take that morphine. I do not want to take that hydrocodone. Because opioids do 3 things to the bowel. Number 1, they decrease the water in the stool, so they make it hard. Number 2, they decrease peristalsis. So it used to go like this, now it just sits there. The third thing, though, that we don't recognize is that it increases that anal sphincter tone. So patients will tell you it's right there, but I just can't get it out. So 3 problems with constipation, or 3 mechanisms. So you've got to use a laxative plus a stool, so a stimulant and a stool softener. Daily doses, you need to prophylax. This is a great quality indicator for your practice. For all of your patients on opioids, go through your charts and see how many have you put on a bowel protocol. Nausea, vomiting. A lot of times with morphine, codeine causes a lot of nausea. Instead of rotating, it's sometimes helpful to treat it. We've all seen the patient that has come with 10 allergies on their chart. And I can tell you when I'm managing cancer pain, we've got to claim some of those back because we need more options. So when we ask patients it, they'll usually say it's just for nausea. Pruritus and rash can also be a problem. And so because of the histamine release, you can treat it with an antihistamine. Confusion. Opioids are commonly blamed for causing confusion. However, I would encourage you to look over the medication profiles of patients because most commonly benzodiazepines, phenothiazines, and muscle relaxants may be more responsible. So take a look at that profile before you jump too quickly. But also consider your metabolite issues. Does the patient have renal compromise? Are they on morphine? Could there be an accumulation of those metabolites? Sedation, same type thing. What are other sources of sedation besides the opioids? And I always tell the nurses, sedation is not respiratory depression. In the hospital, when we have patients admitted for intractable pain, sometimes they have not slept for 2 to 3 days. So now they're very sleepy, but you can still wake them up and they're cognizant. With respiratory depression, we're learning a lot more about this. Patients who are at risk, what some of the predictors are, being careful with patients with sleep apnea, obesity, etc. The other things I'm not going to talk about a lot, myoclonus and hyperalgesia can be problems with high doses, some of the other effects, but most of these side effects can be very well managed. Let's briefly talk about the co-analgesics. Antidepressants are another tool that we have to manage pain. Primarily, the tricyclic antidepressants block the reuptake of dopamine, serotonin, and norepinephrine at that dorsal horn of the spinal cord. So our body during modulation is trying to do that, but these agents can help facilitate that. We have to be careful giving these. For example, amitriptyline is on the Beers list, which means it's a no drug for the elderly population. Can cause some problems with orthostatic hypotension, some other cardiovascular problems. But these agents can be very helpful. And because of their sedative effects, they can help patients sleep at night as well. SRNIs are more commonly used now for pain. Many times for neuropathic pain. Duloxetine is approved specifically for neuropathic pain. Venlafaxine is another. So in addition to inhibiting the reuptake of serotonin, these drugs also block the reuptake of norepinephrine. So you're lacking the dopamine that you get with the tricyclics, but studies have shown that these can be again, effective for neuropathic pain. Pain syndromes such as diabetic neuropathy, post-mastectomy pain, post-thoracotomy pain, etc. Note that the SSRIs are ineffective for neuropathic pain and for most other pain syndromes. So we need more than the serotonin at that dorsal horn. Oops, did I look? Okay, muscle spasms. There are a lot of muscle relaxants available. The key message on this slide that I want you to take away is that these are not recommended for more than 3 weeks. They can cause a lot of toxicities, dizziness, sedation, unsteady gait can be problematic. Now, one exception I have to say, and there's a couple of studies with cyclobenzaprine in treating fibromyalgia long-term, low dose. So there are a few assorted studies out there, but we're primarily indicated to use short-term. Antispasmodics, same thing. Many times with some of the proton pump inhibitors, I think we're using less of these antispasmodic drugs, but they still have a role in different types of visceral pain, cramps, spasms, different GI complications that you see. Sometimes some SSRIs can help, probiotics, so there's our naturopathic component, but again, not used a lot anymore. Anticonvulsants, a very powerful analgesic category. Even though the exact mechanisms are not well understood, we know that these interfere with the transmission of pain. And if you go back to June's diagram, we have the transduction at the hand, then we have the transmission up to the dorsal horn of the spinal cord. What these agents do is that they stabilize the nerve membrane. So they actually prevent the inhibition of calcium into the neuron so that those ions can't change position. So a lot of times you'll generate the action potential along the nerve. This will prevent that from happening. So these are helpful for centrally mediated neuropathic pain that's shooting, lancinating, something like a brachial or a lumbosacral plexopathy, but can also be very helpful for peripherally mediated pain such as diabetic neuropathy. They do have a ceiling dose, and again, Leanne's going to talk a little bit more about this later, but gabapentin is one that is commonly used in practice. The dosing is individualized because of the GI transport mechanism in the gut. Here's some of the others, and pregabalin is now commonly used as well. It has an easier titration schedule compared to Neurontin or gabapentin. So anyway, some advantages and disadvantages in all of those. Let me see. On the carbamazepine, of course, that's indicated for trigeminal neuralgia. And then Topamax you can use for migraine headaches, which is another category of pain that we haven't gone over today. Very challenging area. But a lot of these anticonvulsants can be used in different types of pain syndromes. And then we go further. And again, I guess my message to patients always is that we have more tools available. We keep trying until we get patients comfortable. Clonidine is sometimes used to treat anxiety. We also use it to treat myoclonus, but it can also be used for neuropathic pain. In fact, intraspinal clonidine can be very helpful in intractable neuropathic pain. Baclofen for spasticity, a new Zanaflex, I'll just say that, for skeletal muscle relaxant. So anyway, a lot of options out there, and there's different options that I didn't talk about today. Catherine and I were talking about the use of ketamine, the use of some of the other options when we have intractable pain. Okay, one more case. Dorothy becomes obstupated and is admitted to the hospital because no one told her about constipation and how to avoid it, unfortunately. So what are her options? Well, this is one of our bowel protocols that I've kind of been working on. And on the EPERC website, eperc.com, it's the Education for Palliative Education Resource Center. There are some great bowel protocols on there. But keep in mind, patients need prophylaxis with a stimulant and a softener. Then if there's no stool in 24 hours, you need to use something else. If they still don't respond, we want to try something else. Then there's a third line, and sometimes depending on the situation, we now have a new option for constipation, which is called methylnaltrexone or Relistor. And what Relistor does, or methylnaltrexone, is it reverses opioid receptors specifically in the gut and allows laxation within an hour. In the times that I have used this agent, it has worked 100% of the time, even though that's not what the studies show. It's about 60, but it's a very effective bowel regimen in refractory constipation. Okay, during Dorothy's 1-month follow-up visit, she mentions that she has developed low back pain. Okay, sound familiar? Her back hurts more when she's walking. It sounds like my parents, unfortunately. I'm dealing with pain problems with them now. If you have aging parents, it's a real challenge. Anyway, this pain occasionally radiates down her left leg. So she's got an MRI done, and it shows a partial compression fracture. So what do we do next on Dorothy? Well, Leanne, I think, is going to take over this afternoon and take a look, but I do want to point out that the American Pain Society has some new guidelines out on low back pain. You can find them on the website, or they're also in the journal, but on the website you can actually pull the guidelines off and you do not have to be a member. And I think that's the Society's real commitment to control low back pain, because this is such a difficult to manage population. So in summary, I just wanted to give you a few pearls. And the first one, of course, we always start with the least invasive route. So if patients can take oral, we want them to take oral. Transderm, which I didn't talk about, is very good for stable pain. But if you have a patient with pain that is up and down, it's more difficult to titrate. Use sustained release formulations when possible. Use one opioid if possible to prevent that polypharmacy issue. However, we have to use multimodal therapy. We have to use things that control pain at the peripheral area, at the central area, and modulation, so throughout the pathway. Use co-analgesics to decrease opioid requirements. Initiate one thing at a time to know what's happening. Monitor treatment and response constantly to improve efficacy and limit adverse events. Consider rotating or an alternative route if you have side effects or ineffective analgesia. So, and from now, I'll turn it over to Catherine. Thank you.
Thank you, Janine. I'm always awed by pharmacologists. I like people who understand pharmacology, because I don't. I want to say two quick things. Those of you who have questions and have written them down on cards, please hold them up and we'll collect them. Second thing is, there was a page missing from the documentation tool that's in your handout that lists some of the aberrant behaviors that you can check off, and that we're in the process of copying that for you. Third thing, just a quick thing about Darvocet. I try never to prescribe it, but I have patients who come in on Darvocet and there is no way I can get them off it. They just love their Darvocet. They're 1 or 2 Darvocets a day, and it's not worth fighting over. And then finally, one of the few accomplishments I feel that we've done actually in pain management is that we did at our hospital manage to get Demerol off the hospital formulary except for very specific purposes, and thank you, Pam Hebert, for doing that. Our next talk is a triumvirate of Janine Gomersall, who is the Missoula connection. Janine and where is my? Oh, there we go. Thank you. And David Tegerstrom, who's a licensed clinical social worker with the Advanced Pain and Spine Institute at Community, and Nelson McGreary, who's a physical therapist who works at also at Community. And I've actually heard Nelson talk a number of times and have learned more from him than probably many people. So anyway, I am pleased to have them do their talk about multidisciplinary pain management. You're going to be hearing more about that this afternoon, but this is really geared towards a primary care practice. Janice?
We're going to try this color mic. Test, test. Can you guys hear it in the back? Is that better than before? Okay.
It's because it's your voice. It's not How's that? Is that going to be loud enough? Louder, louder, louder. If they get it too close, you're going to hear a whole bunch of static. Okay, so in the back, if you can't hear me, put your hand up high enough while I'm talking. My name is Janice Gomerson. I'm a family doctor. I work out at community hospital. I do a little bit of everything. I deliver babies. I take care of grandma, grandpa, and everybody in between. My specialty is not pain medicine. I'm a family doctor, and family doctors end up seeing a lot of pain medicine. I actually got interested in working with the Montana Pain Initiative, though, by working with Montana Medicaid. I was a medical advisor for their disease management program from 2004 on, and I was very proud that the Montana Medicaid actually labeled chronic pain as a chronic disease. And that was a little bit before their time. I think a lot of other places did not recognize it as a chronic disease, but they put it right there with diabetes and asthma and heart failure, and that was really good. And so that's how I got involved in this, and then I think I actually got sucked into this. Somehow this year got on the planning committee and realized they actually do a whole lot of work. So this is the last talk of Pain 101 for the providers. You heard about kind of laying the groundwork, and June gives really good explanations for all of us. We always need reminders of that. A little bit about the assessment, and now we're going into treatment. So we had pharmacology, and initially we were going to label this non-pharmacological treatment, but we decided among our little threesome that we liked the word multidisciplinary better, and that's why we changed the name. I'm going to start out a little bit, and then David will put his part in, and then Nelson will put his part in, and I'll be up at the end. Don't be worried about how many pages we have in our syllabus. The last dozen pages or so is really a collection of all of the Cochrane reviews and reviews of the literature on all the different modalities, so that if you are called upon with insurance companies or your patients or whoever to give a reason or at least some literature behind it, you have something to start with. We know that there is not a lot of evidence-based medicine on each and every one of these, but it's at least best practice, and that's what we were getting at. So these two slides are on the rationale for the multidisciplinary treatment, and a lot of this is the same theme that's been going through all of these lectures. The chronic pain is best treated with a combination. We've heard about the pharmacology, and this is the multidisciplinary or non-pharmacologic. You have to treat the whole pain experience, not just, okay, I have the right arm, you have the left arm. We have to do the whole experience of pain. And it's more than just the sensory experience, and you got all that from June's talk, I'm sure. The psychosocial aspects of pain require treatment. None of us argue with that. We know it does. We just don't know how to do it. We don't know how to get the patients into it. And this is where David's lecture is really going to help you. Pain has an affective, cognitive, behavioral, sociocultural, and spiritual dimensions. And if we can tap into each of these, that's where we're going to have the most success. Benefits, all of these. Reduce the anxiety, improve the mood, sense of control over pain, and that's really where I'll put in with a lot of the acupuncture and things like that, giving the patient some control. It's not, okay, you guys have to fix me. It's what can we all do to fix what's going on in my life right now. Make sure that we're always, the goal is to improve function. We are not going to get rid of pain. We are going to improve function. If someone is, I have a patient who I am arguing constantly with workers' comp about getting her the massage therapy and the yoga therapy and things like that. She chooses to continue to work despite her pain. If I gave her narcotics, she would not be able to continue to be a mail carrier. She couldn't drive. She wants to remain functional. She understands she has pain, and these are the things that keep her functional. And I use all the right buzzwords, and I've actually got away with this, and they're paying for it, and I'm impressed with, I don't know, maybe I'm impressed with myself, but maybe I'm impressed with them from listening to me. But I got good buzzwords finally. Improved quality of life. Assessment of pain, again, we heard a lot of this, but really it's the same thing no matter what you're going to end up prescribing. You're going to look at the type of pain, the intensity of pain, the duration of pain, where it's impacting their life, what kinds of needs do they have, and always this last point, is the patient willing to go one step further? Are they the passive patient that wants to sit in your office and you give them a prescription and they walk out of the office? Or are they really wanting to get referred to get the best thing? And sometimes the first referral is not what you end up having the most success with. But they have to be willing, and you have to be willing as a provider to refer them and to give them the pain, give them the outlook. These two slides are pretty much on statistics. Sometimes the patients don't wait for us to do the referring. They go looking already. They're looking for what else will work. The typical Western medicine isn't treating them as well as they need to, so they go looking. 45% have already seen a chiropractor before they even come to me. 24% use massage, 11% use acupuncture, 7% try meditation, and this last one I thought was interesting, especially as I was researching a lot more about the acupuncture. Half your patients are already willing to try it if you would just give them the nudge. Some of them have some hang-ups, but you can modify those a little bit by your words. And hopefully by the end of this talk, you'll have a few of those words to use. Okay, what are we talking about? PT, OT, osteopath, chiropractor, we all know about those. Those are usually acceptable in the mainstream medicine. The patients don't need a whole lot of push to get them into those. Psychological testing, there's a little bit of pushback from that because what are you telling me? It's all in my head? And I usually say, yes, would you like me to draw the pictures? And here's all the afferent and the dorsal horn and things like that. But really it is that they need to understand where they can get the most benefit. And they need to understand their own perspective on pain. And that's where the psychological testing comes in. The psychotherapy and counseling, again, the same sort of pushback. The complementary modalities, that's what we're going to talk about. Not all of these, of course, but we'll give you a little bit about the things that are a little bit more available to the Montana community. Now, if we were in California or Texas or New York, I'm sure there would be many more that are available, but the majority of the practitioners in Montana, we're lucky if we have a couple of these. The rest, you have to travel quite a bit, which doesn't work for chronic pain patients. Persistent pain patients, you're right, I have to change that too. Lifestyle management. There are many, many studies that smoking cessation will significantly improve your pain. And that's a lifestyle management that primary care providers can offer their patients. And basically patient education. Barriers, again, we've talked a little bit about this already, lack of comprehensive assessment. Do we know what the patient needs? Have we asked the patient where their pain is, how long their pain lasts? But more importantly, how does the pain affect what they want to do yesterday, today, tomorrow? We all feel like patients may not be receptive to what we suggest, and that's where that statistic for acupuncture. Half your patients really will do it if you suggest it. We know that in smoking cessation, that after 3 times of the primary care doctor saying you need to quit, they're a little bit more receptive to that. Lack of support, lack of follow-up, and some of this is the family members and their social support system. This is probably what our team wants you to take away from the whole lecture, is the spider web. We actually wanted Tinker Toys, and June did that one, but the idea that we're all together, all providers for the patient, all the providers to give the medications, to give the multidisciplinary, the providers who are actually doing the hands-on, everybody is intertwined. And just as a spider web, as soon as you break 1 or 2 of these little supports, the whole thing falls apart. So where's the patient in this and where's the provider in this? You can look at it any way you want. But we're all interconnected, and the best way to have a nice, strong, functional spider web or patient is to have all of these things all interconnected and communicating with each other. We hear about red flags for all kinds of diseases. If you have, pain that wakes you up in the middle of the night, you got to worry about cancer pain, this and that, all these red flags. Well, now I'm talking about yellow flags. Yellow flags are the things that let you know which patients are going to move from acute pain that they get over in a month or two to the persistent pain that lasts for a long time, interferes with their functional level, interferes with their job, interferes with their interpersonal relations with their support system. And that it's not really that you should think of it as poor prognosis. It's more that you should think of it, okay, if they have this, let me get on this a lot faster than I normally would have. Here's the table. Different kinds of things. You can see affect, behavior, beliefs, social, work. These are the kinds of things that you can ask patients, that you can document in your note. And when you document these kinds of things, this helps you when you want to refer early on to a yoga practitioner or a massage therapist. These are the kinds of things that you can use when you're arguing with the insurance adjuster. Different kind of modalities. The first two are the ones that pretty much throughout Montana we have access to. We have counselors, people who can do testing, who can do cognitive behavioral therapy. We have those available in most of the communities or within 100 miles for most of the people. PT and OT as well. The other modalities I'm going to cover at the end. I'll show you how to pick a provider, how to make a referral to the provider, and what kinds of things to think about with those providers. Okay. So nobody raised their hand while I was talking.
How's that? People hear me all right? Well, good morning. As been noted, my name is David Segerstrom. I'm a licensed clinical social worker, board certified psychotherapist, and I'm going to talk about pain management psychotherapy. I'm going to ask you to bear with me this morning. I'm going to change my presentation a little bit, and the reason is that the information that, if you look through the slides that are available to you, is going to be a lot of information that's been mentioned in some significant ways already. I want to reinforce that, but I'm going to do so in a manner of going through the slides, but as I go through the slides, I'm going to ask you to listen to a story, a patient's story. And this patient is a cowboy who couldn't cowboy anymore. And my challenge to you is that as providers in Montana vernacular, it's time to cowboy up. Cowboy up and do good comprehensive assessments. It's time to buck up and do the referrals that are needed. So let me tell you a little bit about Cowboy Joe. This gentleman walked into my office immaculately dressed in Western attire. He looked like Garth Brooks right out of a magazine. Immaculately handsome cowboy. But what you also notice very quickly is that he was walking only with 2 canes and no legs, all upper body strength. Immediately found out that there was one time in which he made a good living as a provider for his family, as a foreman on a large ranch in Oregon. One day they were loading large bales onto a tractor trailer from a loft. One came off, knocked him off onto the concrete floor and broke his back. The day that he walked into my office, he had had 5 back surgeries. He had an attorney that was working on his case in Oregon. The attorney had missed a deadline and he lost his settlement. He was involved in a lawsuit over that issue. He also was battling the VA for his VA compensation and pension because his original back injury had happened in the Navy. He was very angry. He was very angry at his attorney. He was very angry at Oregon work comp. He was very angry at his pain. And he was significantly suffering. As you've heard earlier, the biopsychosocial model is viewed to be the appropriate model for treating pain. I cite Dr. Engel in the slides and in your handouts. And this portion I think is most important, is to believe that pain problems are not conceived as either physical or mental or as simply biological or psychological. Rather, they are always physical, mental, physiological, psychological, biographical, and biological. So Joe and I began to get to know each other. As you can see, immediately he presented with a number of psychosocial issues. The issue of his independence, because he was a very independent individual, was key. He was determined he was going to continue to walk, but it really affected his independence and certainly exacerbated his pain by trying to walk and use that upper body strength. So with some intervention and looking at his attitude and approach, he responded well to humor. So one day I turned to him and I said, Joe, I said, I want to tell you about the guy that was sitting in the doctor's exam room waiting for the physician to come in. And while he was waiting, he was banging his head violently against the wall. The doctor walks in and he says to him, what the heck you doing? He says, oh, doc, it feels so good when I stop. Joe was able to take that because he had a great sense of humor and begin to look at how much he was continuing to cause himself pain and suffering by trying to walk. When he learned that with a scooter and he could use his tricked up pickup with a hoist in the back of his pickup and be totally independent and go and not hurt so much because it took such an effort to walk, he began to see that his attitude and approach needed to change. If you look at attitude and approach in Montana, the words I used earlier are very common. Cowboy up, buck up. We're taught to avoid pain in this society, minimize it, ignore it. So it's important for Joe to begin to deal with it. You'll see reference to it in the slides. The depression was there, the anxiety was there, the anger had to be dealt with. He had a great work ethic. How he applied it caused him a lot of suffering. One of the things he could still do was mow his rather large yard by riding his lawn tractor and sitting on the seat and trim the yard. Well, he'd get up and he would follow his work ethic of if you start something, you finish it. If you do something, you do it right. So he would push himself all day till he got it done. Often not taking breaks, frequently not taking his pain med. And then at night, he would be very angry at himself because he was hurting. He would be unbearable to be around, so the family stayed clear. And he would take it much step further than that cycle that I see so often. He would then punish himself by not taking his pain med at night because he figured he deserved to suffer by the choices he made. This is how convoluted the thinking and the attitude and approach we'll often see. He had loss and grief issues, function, his beloved hunting. It was very difficult for him to find some way to be accepting of not being that active provider for his family, fighting for his Social Security, fighting for his lost compensation, etc. His self-esteem was affected to the degree that he was never suicidal, but he was often very despondent, withdrawn, and emotionally unavailable to his family. Certainly there were finances, stresses, relationships, as you can see, and the unemployment. Control for Joe was an issue. What helped Joe was the ability to begin to understand that his attitude and approach was counterproductive. It was helpful for him to begin to learn some behavioral health techniques. He was very creative. He was an artist. It was very difficult because of his low self-esteem to get him to use his artwork as a way to work the pain gate theory. But once he learned that that would be a way that for a while he could get some relief from his pain, he was open to that. He needed meaning and purpose. We were fortunate that we were able to get him referred to an excellent vocational rehabilitation counselor, State Voc Rehab Services in Great Falls. Unfortunately, that person is now retired. But with her help and efforts, we were able to move a garage onto his property, set a slab, get it wired, and set up a woodworking shop. And the first thing that he was able to do was build a porch swing for his wife that he'd been promising for years that he was going to do. So we began to find some more of those issues associated with what is function and how Joe and his family defined function. Attitude and approach illustrated by the sense of how he would fight, resist, try to cowboy up against the pain, create that cycle of be angry and frustrated himself, and then suffer more by the poor choices he'd make with his activity. So we work towards being more accepting. I choose to use the word accepting rather than acceptance because it's an active verb. There are times that we can be more accepting of our pain or our patient's pain than other times. It doesn't mean we have to like it, but we can develop that working attitude, what it means to work with the pain, to listen to the messengers and some of the other things we've heard this morning. So fighting it is not the best approach. What do I do now? All I've ever known is to work my way through it or ignore it. It's the best I can. Are you telling me I'm supposed to do something how I'm supposed to do somehow like it in my life? The italics for it is just a point of emphasis. How often do you find patients refer to their pain as it? Go back to your 8th grade and freshman high school English. What are personal pronouns? He, she, and it. It's a subtle way, and I think I missed this for years, but it's a subtle way of patients being able to avoid it not being my pain. It's this third person. And so with Joe, we had to deal with him being more embracing of the pain, to be less angry at it, which meant he was less angry at himself, to be more proactive in problem solving, even with working with the attorneys, but also helping him understand that there were times in which he and his wife, as assertive and as aggressive as they began to be in trying to solve their problems, whether it was the compensation or the attorneys, etc., that there was a time in which they needed to get on with their lives. And they put them on the shelf. So management comes in different forms. So as illustrated by the picture on the continuum, that individuals, we try to help them move along that continuum of the fight, resist, cowboy up attitude that doesn't work and continues to cause more suffering, and moving towards being more accepting of the pain. As noted before, sort of the accepted treatment choice that is recommended for pain management from psychotherapy perspective, and it does achieve significant results and is efficient. However, maybe this is part of my stubbornness, but the social worker may says one shoe does not fit all. Therefore, often I will use multiple modalities depending upon the unique clinical picture each patient presents. Being board certified in clinical hypnosis, I find it very useful to teach behavioral health techniques of self-hypnosis, guided imagery, and relaxation techniques. Grief therapy, dealing with a loss, ego states therapy. With Joe, that was important because he also suffered from post-traumatic stress disorder due to a violent father in his upbringing, and he had a very strong internal critical parent. And for him to understand that critical parent drove him to a lot of those decisions that were poor decisions because he was very effective of shoulding on himself. I should do this, I should do that, etc. So I shared with him that there was an 11th commandment that didn't make it down the mountain. That 11th commandment is, thou shalt not should on thyself and others. Joe loved humor. It helped move, it helped his understanding. Narrative therapy, it helped Joe to begin to look at his life story and understand that when his anger and his reactiveness, he was no longer the author of his life story. And he could begin to rewrite that and become more of an active author of that story. Utilized eye movement desensitization and reprocessing EMDR to address that abuse, the trauma from his childhood. A quick note of caution or alert. If you have a chronic pain patient that presents with a diagnosis of post-traumatic stress disorder and they have active symptoms, refer them immediately to get the PTSD addressed. Any attempts, from my perspective, of being able to address a lot of the other psychosocial issues that I've illustrated there are going to probably be very difficult to be effective because those symptoms are going to continue to create that arousal, the vigilance, the tension's going to be there, and that psychophysiological response, that mind-body connection is going to activate, aggravate, exacerbate the pain experience.
Is EMDR your favorite method of treating PTSD?
First choice. First choice. As indicated before, instruction in pain management behavioral health techniques, guided imagery, self-hypnosis, also some self-soothing techniques, even the butterfly tap from EMDR, very self-soothing, hand on chest, same warmth, comfort, again, self-soothing. Group therapy, support groups. There was a period of time that was fortunate to have a sufficient number of male patients who were willing to be in a support group in Great Falls. And Joe was one of the first members in that group. And it meant a lot to him because he found out he was not alone. And that's what you'll hear a lot in terms of the support groups for chronic pain. There's someone in this group that does understand. Cognitive behavioral referrals. These have been mentioned before. These are to reinforce the need to make referrals. There are different resources out there. There are excellent websites that are informational. Some of them have online support groups. You may be familiar with them. The Chronic Pain Association of America, the American Pain Foundation are excellent websites. Spirituality, that was also important with Joe. He was not a religious man, and in fact, he had a lot of anger towards religion because of issues earlier in his life, but he loved the outdoors. And one of the things that he missed was being able to hunt. And again, that was another anger for him. But when he had the opportunity to serve on a task force with wildlife, state wildlife authorities in Montana to develop the rules for hunting for disabled persons, then he was able to get out and enjoy. And the main meat stable for them during the year was their deer and elk. And so he was able then to go hunt from the road, and it made a difference. But he also gave him a chance to get out there in the outdoors. Having a scooter gave him a chance to be out there, where before that was experienced very much as a loss. I threw this in. There was discussions earlier about brief screens. In our practice at Advanced Pain, we use this just as an initial screening instrument to get some handle on what psychosocial issues may be active. So if you would like to use this, you're welcome to. Generally, we view it, if you start to getting to 3 or 4 answers in there, that it is an automatic referral for evaluation for psychotherapy. So one of our successful patients, in terms of being able to be more functional, she was able to perform. She says the next one is a sad little blues tune about love and pain that I wrote before I started taking Celexa.
Thank you. Good job. Does that sound right? Okay. I brought a couple notes here because I want to remember some of the things that some people said earlier. And I also am going to try to go really quickly here because I know Janice has a whole lot more to say. And so since I am going to be back later this afternoon talking about, excuse me, the more challenging type people that we'll see, some of the people like Dave was talking about just then, I can get into a lot more details later. Can you still hear me, or is it going off? It's a. Sorry about that. How about that? Okay. All right, good. First off, I am Nelson McGarry. I work at Community Medical Center in Missoula, and I deal almost exclusively with people that have persistent pain. But what I'm going to talk about just this morning, and I'll get more into that persistent pain stuff this afternoon, is just when you send somebody to physical therapy for a pain issue, what is it that's going on? And I think a really important place to start is that when people are injured, when people have pain, almost always it just goes away by itself. And it's important to just realize that that's the case. How many times have you hurt yourself and it just got better? We're amazing reparative machines. We repair ourselves incredibly well, and we do this over and over and over through our lives. When it doesn't happen, something's going wrong with that process. We're not allowing that to work the way it's supposed to. And a general theoretical perspective is helpful here. Mueller and Maloff in 2001 in the Physical Therapy Journal summarized about 50 years of physical therapy practice and theorizing with this physical stress theory. And I think it's really a helpful perspective to get a big overview about what we do. Basically, the idea is that our body's tissues respond to stress in a very consistent manner. If we put too much stress on them, more than they can handle, they become injured, and that's almost always associated with pain. If we don't put enough stress on them, they become weak, and then they're more susceptible to stresses that they're going to encounter later. So what we're trying to do as physical therapists is ride the balance here. Put enough stress on people so that they can handle their daily activities. Don't put so much stress on their tissues that are aggravated that they can't get better. And when we think about physical stresses, we're thinking really about applied forces. You have to understand where they're being applied, the direction they're being applied, their intensity, their frequency, that sort of thing. So the main treatment principle, I think, for pain with physical therapists is first to just try to identify what the connection between what people are doing in their daily life is to their pain. And this seems like it should be so obvious, and so often it is, and that's why people tend to get better most of the time. If you're walking along and you twist your ankle, you quickly notice that when you twist your ankle again, it hurts a lot, and you don't do that. Where it becomes problematic is that when pain develops slowly over time especially, or it's not one large event that causes the pain, but lots and lots of little events piled on top of each other, then it becomes hard to understand. And when people go first to you and then are sent to us, they've tried everything they can think of. We need to look at it real systematically, see specifically how they respond to all sorts of different movements. And then by doing that, we figure out the specific stresses that are irritating them, and then show them how to gain control over their pain by controlling those physical stresses. So as an example here, this is a very common type patient that we could see, a 31-year-old male who has low back pain, and this would be somebody that's just used to having aching in their back all the time, always achy, just thinks that that's sort of part of being old, and they're thinking that that's what they are at 31, and it's true. At 43, I don't think 31's too old anymore, but anyway, and this is a person who, although he's physically active, although he's golfing, playing softball, that sort of thing, he gets out there and he's at work and he reaches down and picks up a file off the floor and throws his back out. Well, what we need to do to help this person is to help them to understand that it wasn't just that one event of picking something up, but that over and over throughout their day, throughout the past years, they were continually putting twisting stresses on their back that led them up to the point that got them there. If we can bring their awareness to a point of decreasing those twisting stresses, they can first off eliminate the pain they do have, and then later eliminate its recurrence. The second treatment principle, this is now actually trademarked by the American College of Sports Medicine, exercise is medicine. And it's tremendous medicine, and this is what I brought, I wrote this down. There it is. For this, what June was talking earlier about, what are some of the consequences of persistent pain, and she said depression, hopelessness, impaired mobility, impaired physical function, decreased socialization, cognitive dysfunction. Well, in many ways, these are the same sort of things that happen with deconditioning and decreased activity. In fact, I think it's been excellently described that maybe one of the, that physical exercise is not an antidepressant, but it's actually a depressant not to exercise. We've just gotten into a pattern of living that's so different from the way we were designed to live, so that we can be so inactive these days. But as we go through our lives, doing less and less, we put ourselves at higher risk of all-cause mortality, cardiovascular disease, osteoporosis, some types of cancers, and things such as depression and anxiety. Just regular aerobic activity is first-line treatment for all of those. And so with for example, a 68-year-old male with a 12-year history of work-related low back pain, what I'm going to look at with somebody like that is not so much what's the specifics causing their pain, but how do we get them more active? How do we get them doing so much? One thing that I've heard so often from people that come in 70 years old, they can maybe walk 300, 400 yards a day, and you suggest, well, you use a cane. And they say, I don't want to do that, I'm going to get old. It'll make me feel old. Well, I think that's absolutely ridiculous. And although I understand why people think that, and I am aware of the sensitivity necessary there, it's so important that people become active. And if they become less active because they're afraid of that maybe if they use a cane that will actually make them worse, it's our position to educate them and to explain the level of importance there. So the last thing, and then I'm going to let Janice wrap up, is just modalities. This is another thing people think about with physical therapy. And I think the truth is they can all be beneficial. I think what it all boils down to is cost. And if we, and there's going on in this nation a big dialogue about how much do we want to spend on healthcare. Well, at some point, it's going to be awfully difficult to send people in and have the government pay a lot of money to have somebody apply modalities. I'm all for any way these can be done inexpensively, any way people can do them on their own. I think it's great, but I think we have to be careful about their the fact that they can be relatively expensive. So with that, I'll just let Janice come. So overall, as far as physical therapy for pain, the big pearls are you want to steadily increase activity. If people's activity level is low, we need to increase it. the problem with that is oftentimes when people increase their activity level, they feel worse. So they don't want to be active. And that's why it takes a professional that understands a lot about biomechanics, motor control, those sort of things. That's what our training is. And we can understand how to deal with those issues specifically. And then we want to learn we want to take these people and we want to show them how to make adjustments in the things they do throughout their day to allow them to reduce their pain and then gradually increase the kind of physical stresses they're dealing with so that they're more stress resistant through the rest of their life. And then if necessary and if there's the ability to do that, modalities can be helpful.
Okay, I think we're perfectly on time, so we do get to have lunch at the right time. Okay, a little comment about the evidence. I was talking a little bit about evidence-based medicine, best practices. It would be so wonderful if we had 1 million randomized controlled studies and one modality against another modality to show you exactly what you needed to use. We really don't have that. We have a little bit, we have some information, but, and I'll present a little bit of that, but what you have to go away with is just because we don't have the study that shows that this modality is perfect for this type of back pain or headache or whatever, doesn't mean you don't try it. You still look at the patient. You still try to find something that works for the patient. And it's probably because we don't have funding for it. We don't have a lot of money for these kinds of modalities. We went through this a little bit. June did a really nice job. We know that acute pain is something that is a little bit easier to study. It's short-term. Chronic pain, persistent pain is not. Often it starts with an injury, but it doesn't always start with an injury. Nerve injury is what really causes more of the problem. We know the ideas about phantom limb pain. You know, my foot hurts. You don't have a foot, but it hurts. You know, we know there's a lot of other things involved. We talked a little bit about allodynia and different kinds of recruitment of pain receptors and treatment of the pain, and I think that all that comes into play. And we think about all the different modalities that you can apply to all the different kinds of pain, and you know we just don't have the studies that show one way or the other. We talked a little bit about the exercise treatment and the physical therapy and the cognitive behavioral therapy. And because there are so many factors involved in not only how the pain is caused, but also the perception of the pain, that's probably why a lot of these actually work better than we would think otherwise. There's several different reviews. This one is a generalized review of the literature. American Pain Society looked at all the different reviews and randomized controlled trials of anything that looked at least one or more of these therapies. This is a listing of all the different kinds of therapies that they looked at. Evidence, there's good evidence, fair evidence, different kinds of parameters for the different kinds of evidence. This isn't saying one works or doesn't work, but this shows there is good evidence for some of these. The fair evidence just means the right studies probably haven't been done. So cognitive behavioral therapy, exercise, spinal manipulation, rehab, those kinds of things have been very well studied for chronic and low back pain. There's fair evidence, acupuncture, massage, yoga. Well, Vini yoga is the only one that we're really going to talk about here. Those are good for low back pain as well. We looked about different kinds of benefits to different things. Again, we really have a paucity of evidence out there. So we use what we have. We hope we get more. But don't hold your breath because there's not a lot of money in this. A lot of pain states need multiple modalities. If you try one, it doesn't work. If you try one, it works a little bit. Keep trying, keep adding things in. The different kinds of evidence, moderate evidence for acupuncture that I'll talk a little bit about. The weak evidence for the chiropractic. This is for fibromyalgia. It doesn't mean you don't use it for low back pain. Persistence, a big deal. You don't try something once. Everybody rolls their eyes every time the chiropractor says, well, you're going to need 10 visits, and everybody says, oh, the chiropractors just want more money. No, it's persistence that pays off. The same with acupuncture. You do not expect to have complete treatment with 2 acupuncture treatments. You need a series of them, and it's because of the way it works. It's very important that you need to do your exercises on a regular basis for low back pain. We all know that. Oh, I used to do my exercises. Yeah, I haven't been doing those for a while. Oh, you have back pain again? Yeah, well, why don't you get back into doing your exercises? The provider support is probably what's going to push them the most. Okay, making referrals, understanding what to do. In Montana, you really have to find who's available, who's in your community, how are you going to know if they're good. Think about it yourself. How do you decide what doctor to go to? Okay? It's word of mouth. It's going in and trying. If they're complete nincompoop when you walk in, you never go back to them. It's probably, that would be the best way for you to find someone to refer to. We can't all afford that. We can't go to all the acupuncturists and all the massage therapists, but you ask around, you find out what works. When a provider gives you feedback, if I send them to a massage therapist and I get nothing back, I don't know that they're any good. I want a progress note. I want something in my chart that I can use when I'm writing back to the insurance agencies. Mental health professionals, these are some of the ideas of where you can find good ones. David gave us some good ideas of what you're doing. Mainly, are they interested in treating pain? Do they do a good job? You know, obviously, mental health professionals are going to be licensed. That's not going to be hard to find. Physical therapist, occupational therapist, you have lots of different settings. You can find them. Again, the interest in pain treatment. That's why we use Nelson here, because he's got the interest. He's been doing it for a long time. What kind of facilities are available? There are different things that help different kinds of pain. Chiropractor, they are licensed in Montana. They're licensed pretty much all the states. It's basically, you know, they have their education, they have their continuing education. You find someone that works with you, you can refer them in. And chiropractors don't really need a lot of referral. They are usually reimbursed pretty well. L&I reimburses them right off the bat. Patients don't have to go to a medical provider first before they go to the chiropractor. If you want to refer into the chiropractor, you call them up and you give them their name, their insurance information, and what you want them to treat for. Most of the chiropractors do back pain, headache. Those are the main things that they'll do. They do a little bit of basal stem, you know, things like that. Massage therapies, some states have licensing boards. In Montana right now, there's not a license, but in July of 2010, there will be a board. It's been fraught with a little bit of politics back and forth. There's a lot of people who need to be grandfathered in. It doesn't have as much teeth as it probably should have. In other states, Washington State had any willing provider. So as long as you were able to do, you know, and said you would do it, you could bill into several insurance agencies. We don't have that in Montana right now. So there's a little bit of problem with that. The main thing is looking at their interest and their knowledge. Certification for massage therapists really doesn't mean anything. You can go online and get a certification with a 5-hour course. You can have a certification with a 500-hour course. You need to find out what the training is, what their interest is, and how much they know. There is a national certifying board for therapeutic massage and bodywork. And they are working with many different states. I went online, there's about 34 states. Don't equate advertising with competency. Just you talk to them and you find out. And again, can they give you a progress note that tells them what the goals are, how they're meeting the goals, and what's going on? Acupuncture, they are licensed in some states, but not all the states. There are different specialties. There are acupuncture that use lots of needles, acupuncturists who use only a few needles, depending on if they understand the meridians and how you can actually affect the pain. You want to make sure that you have a person who is interested in pain and knows all the different things. Acupuncture includes also herbology, medicinals, and things like that. Right now, you have to graduate from a school that's accredited in acupuncture, and there's actually 5 or 6 that are probably good enough. You have to be able to test out. There's a national test. And right now, they've increased it from 1,000 hours of practicum. Now they have to have 3,200 hours of practicum to be able to take the test. The couple things to think about. Patients think there's a religious association with it. There isn't. You don't have to worry about that. And the needles are like a cat whisker. It's not very much. I used to keep some needles in my office and put them into my skin just to show them that it just separates the skin as you put it through. It doesn't hurt. And they're very, very flimsy needles. Yoga, Vini Yoga is the only one. Vini Yoga is the yoga that works with functional status. They'll give them maybe 20 minutes of exercise to do, not an hour. It's not who can do the best back bend. You know, it's really working on the emphasis is function, not form. They do some breathing, they do some chanting, that's all part of it. Look for a yoga therapist, not a yoga instructor. They can do a $7 course or $7 a time class, or they can do $40 a time individual instructions. You probably need at least one individual instruction. If you refer, you can get some health plan coverage for yoga, but most of the time you can't because there's no licensing. Deep breathing, the Alexander technique is one that started out with singing and getting into the right posture to do the right singing, moved into asthma and respiratory, and now it's more into relaxation. There's not too many providers and there's none in Montana, but it is a very effective technique. Lifestyle changes, lots of different things. The quit line, the readiness to change. When we talk about spirituality referrals, people say, well, I don't believe in this, or I don't go to a church. It's the willingness to be inspired. That's what spirituality is. And if you can get them to be inspired into a higher level of functioning, that will work. A lot of the group visits are starting to get reimbursed, but it's still a little hard to do that. Okay, making in the referral, figure out what you want to occur. What is it that you're looking for? These are some of the ideas for cognitive behavioral therapy. What you want to do is balance everything. For PT, reconditioning, stretching, OT, exercise, basically make it low impact so you don't have a lot of problems and more injuries. I always tell my patients, don't you dare go more than 30 minutes at a time until you're in shape. Those last 15 minutes of 45 minutes is when they get the injuries. Okay, so when you write a referral out, you find out who's in your community, what they need from you to make the referral. The chiropractors really don't need a lot. You don't even need a prescription. Acupuncture, massage, yoga, if you write them a prescription, they can take it off their flex plan if their insurance won't cover it. I've actually had more success with LNI in writing out these referrals. Massage therapy and yoga seems to get better and reimbursed when they're part of a physical therapy plan. When you have a spine and pain center and you refer in and it's part of the whole overall plan, then that works really well. Yoga, I'm still having a little bit of problem. Yes?
One thing you haven't mentioned is body talk, which is actually growing and actually is being accepted by Medicare in a lot of states.
True. I think in one of my references at the very end that I have some information about the different kinds of things like that. I don't have a lot of studies on it, you're right. Some of, when you do cognitive behavioral therapy, they get a lot of that in there too.
I used to get a lot in emergency rooms. They're just growing fast.
This one is basically the patient and the support persons knowing and understanding and not pushing or restricting too much. And this is where you have to work, and in a family practice setting, we get a lot better with this because we are used to working with the whole family and the whole setting with that. And that's the same thing that I said before. And then in the end of the slides, I have some of the literature so that you can use that in terms of trying to get approval. Okay? Now we get to have lunch.